Welcome! In this high-yield explainer, we're diving deep into a major bacterial player, Streptococcus pyogenes. We're going to break down all the must-know clinical science and the definitive lab tests you absolutely need to nail for your exams.
So we're going to tackle this just like you would in a real clinical scenario. First, we'll look at the patient's presentation, all the classic diseases this bug causes. Then we'll head over to the lab to see exactly how we prove it's the one causing all the trouble.
All right, at its core, you got to think of S. pyogenes as having two distinct faces. First, you've got the suppurative or pus-forming infections. These are caused directly by the bacteria. And then there are the non-suppurative complications, a really dangerous delayed aftermath that's actually driven by your own immune system.
This slide right here gives us the full clinical roadmap. On the left, in the suppurative column, you see the immediate damage from the infection itself. We're talking everything from a simple sore throat to some really severe skin infections. But that non-suppurative column on the right, that's what's truly insidious. This is where the body turns on itself, leading to devastating conditions like rheumatic fever.
Okay, so let's start with those suppurative infections, the active pus-forming diseases you're going to see day in and day out in the clinic.
To lock these in for your exams, we've got a fantastic mnemonic for you. Just remember, pin tips. Let's zoom in on the ones with the most classic, can't-miss visual presentations.
Let's kick things off with the I in our mnemonic, Impetigo, which you'll also hear called pyoderma. This is a classic superficial skin infection, and you'll see it a ton, especially in kids living in warmer climates. And this slide, this shows the pathognomic sign you absolutely must recognize. These are the classic thin, papery, honeycomb-like crusts. They form from dried-up serous fluid, usually hanging out around the nose and mouth. When you see this on an exam, your first thought has to be Impetigo. Okay, next up, the E in pen tips stands for Erysipelas. I want you to think of this as a very specific and frankly angrier type of cellulitis. The key is that it involves the superficial lymphatics, which gives it a really distinct look. Just look at this presentation on the malar area of the face. The skin is bright red, it's swollen, and it has this characteristic peau d'orange texture. You know, like the peel of an orange. And importantly, the borders are usually really sharply demarcated. Now for the N, necrotizing fasciitis. This is the one you've definitely heard of, the infamous flesh-eating disease. It's an absolutely devastating, deep soft tissue infection that just tears along the fascial planes with terrifying speed. This is a true surgical emergency, no question. So the crucial clinical point is this. The patient often presents with severe, just excruciating pain that is completely out of proportion to what you're seeing on the skin, which might look minimal at first. That discrepancy, that's a massive red flag. Now let's shift gears and talk about those non-suppurative complications. The key here is that the bacteria might be long gone, but the real danger is just getting started. We're talking about serious immune-mediated conditions that pop up weeks after the initial infection has cleared. The engine driving these complications is a fascinating and, frankly, dangerous process called molecular mimicry. It's basically a case of mistaken identity. Parts of the S. pyogenes bacterium look almost identical to our own tissues. So the antibodies we make to fight the bug, they end up waging war on our own cells. Now, what's really incredible about this slide is just how specific this mimicry is. You can see the M protein mimics heart muscle, the myocardium. The C carbohydrate mimics our cardiac valves. This cross-reactivity is exactly what leads to the heart damage and acute rheumatic fever and the kidney damage and post-streptococcal glomerulonephritis. So you've seen the clinical signs. You have a suspicion. Now you need to prove it. Let's head to the lab and walk through the exact steps we take to confirm that Streptococcus pyogenes is the organism responsible. The diagnostic pathway is super logical. It all starts with getting a good specimen right from the site of infection. From there, we take a quick peek under the microscope for some initial clues. Then we culture the sample on agar to grow the bacteria in huge numbers. And finally, we use specific biochemical tests to make the definitive ID. So under the microscope, after a gram stain, we're looking for this classic appearance: gram-positive cocci arranged in chains. And as you can see by comparing these two images, the chains are often way longer and more beautifully defined when you make a smear from a liquid culture broth. Next up is the culture. On blood agar, S. pyogenes is a beta hemolytic strep. What does that mean?
It means it completely blows up the red blood cells in the agar, creating this wide, clear zone of hemolysis all around its tiny pinpoint colonies. This look is highly characteristic.
All right, now for the specific biochemical tests. These are absolute favorites for exam questions because they are exactly what we use to tell S. pyogenes apart from other similar-looking bacteria. First up, the catalase test. This is the crucial first fork in the road for identifying any gram-positive cocci. Staphylococci are catalase positive. They'll bubble up when you add hydrogen peroxide. But all streptococci, including our culprit, are catalase negative. No bubbles. Simple as that. Next is bacitracin sensitivity. This is a high-yield fact to memorize. Group A strep is sensitive to the antibiotic bacitracin. You can see it right on the plate, that clear zone of inhibition where the bacteria just could not grow around the disc. That's a huge clue, because other beta homolytic streps, they're typically resistant. Now check out the CAMP test. Its whole purpose is to differentiate Group A from Group B strep. S. pyogenes is CAMP test negative, so you see nothing, no change. But Group B strep, S. galactaceae, would create that characteristic arrowhead shape of enhanced hemolysis right where the streaks meet. Okay, let's wrap this all up by focusing on a few more high-yield comparisons that are almost guaranteed to show up in one form or another on your exams.
So Spiogenes makes two different toxins that lyse red blood cells, streptolysin O and S. For diagnostics, the key difference you need to know is their antigenicity. Streptolysin S is non-antigenic. Our immune system just ignores it. But streptolysin O is highly antigenic. It triggers a really strong antibody response, and that's why measuring the anti-streptolysin O, or ASO, titer is such a useful test to confirm a recent infection.
And this is a critical distinction for your exams. The ASO titer is a great marker for a recent strep throat, but, and this is a big but, it's often misleadingly low or even negative after a skin infection like pyoderma or its complication, PSGN. In those cases, the better test is the anti-DNase B antibody titer. You have to remember that pairing. And finally, this table puts the key lab differentiators for Group A and Group B strep side by side. You need to know this cold. If you see a beta hemolytic strep that is bacitracin sensitive and CAMP test negative, your answer, without a doubt, is Streptococcus pyogenes. Ultimately, the key thing to take away is that direct line connecting the clinical picture you see in the patient to these very predictable patterns in the lab. The ability of this one organism to cause both direct pus-forming infections and then later trigger devastating autoimmune disease through mimicry is truly remarkable. It really leaves us with a final question. Is Streptococcus pyogenes the ultimate bacterial master of disguise?